So you just try to organize the information. So first, this is the humerus. And for the type of the bone, this one is a long bone. Any long bone has upper end, lower end, and shaft. This one, long bone. So where it's located? It's located in the arm, called the bone of the arm. So the humerus, when we speak about the parts of the humerus, so it has upper end, lower end, and shaft. Okay. If you look at the upper end, you will find that there is head and there is neck. This one we call the anatomical neck. Anatomical neck of the humerus. Then we have two tuberosity. This one bigger tuberosity, greater, and we have the smaller, lesser. Okay, greater tuberosity and lesser tuberosity. In between there is a groove. You can see here. This one we call the bicipital groove. Okay, or sometimes called the tubercular groove. Okay. This one will be for the tendon of the biceps. Lodges the tendon of the biceps. Okay. Then if you move down here, you will see the deltoid tuberosity. Deltoid tuberosity. Okay. Then for the lower end, there are two epicondyles. Okay. We have the most prominent, we call the medial epicondyle, and the lateral epicondyle, which will be not prominent like the medial one. And above the condyle, there will be the medial supracondylar ridge and lateral supracondylar ridge. Okay. If you look here, you will find two processes. Okay. So this one we call the capitulum, which will be the lateral one, and the trochlea, which will be the medial one. Okay. Above the two processes, there are two fossae. Okay. Here we have the olecranon,
will be behind, right?
coronoid
and
fossa,
conoid.
and the radial fossa. Coronoid fossa and the radial fossa. So we have two epicondyle, medial and lateral. Two processes will be the trochlea and the capitulum. Above there will be two fossae, will be the coronoid and the radial fossa. Okay, the coronoid and the radial fossa. When you move at the back, you will find only one fossa, big fossa, which will be the olecranon fossa. Okay. For the shaft, we have anterior border, we have a medial border and lateral border, and we have also surfaces, medial surface, lateral surface, and posterior surface. On the posterior surface, there has to be a line, we call the spiral line, or we call the radial line, or we call sometimes spiral groove or radial groove. This one here will go all around the posterior surface like this, not prominent here very much, but it will be in this side. This one very important for the radial nerve. When there is fracture in this area, so the radial nerve very tend to get injured. So those are the important parts and features. How to know right from left. Also 3 points. So first we have here the head must be directed upward, and then we have the olecranon fossa must be directed backward, and the most prominent epicondyle, which will be the medial epicondyle, so this one will be medially. Okay, so now we identified up, medial, and behind. So this one is right humerus. Okay. Now for the important muscle attachment, we forgot to mention that we mentioned before that there is anatomical neck, right? There is also surgical neck here. The anatomical neck above the tuberosity and the surgical neck below the tuberosity. Okay. For the attachment, first we attachment of the lesser tuberosity, they give attachment to subscapularis muscle, and the greater tuberosity, they give attachment to other 3 muscles, which will be supraspinatus, infraspinatus, and teres minor. Okay, supraspinatus, infraspinatus, and teres minor. So that's why we call SITS. Okay, supraspinatus, infraspinatus, teres minor, and subscapularis. This one we call the rotatory muscle of the shoulder joint. So those muscles will be forming like a socket to the head of the humerus. They prevent the upward dislocation of the shoulder joint. Okay. For the attachment of the deltoid tuberosity, here will be the attachment deltoid muscle. Okay. For the anterior surface, we have here the coracobrachialis and the brachialis. Upper part coracobrachialis, lower part will be the brachialis. Behind, we said that we have the spiral groove. Here will be the attachment of the triceps. So above the spiral groove will be the lateral head of the biceps. Below the spiral groove will be the medial head of the biceps, of the triceps, sorry. The long head comes from where?
Infraglenoid.
Yes.
Yeah, infraglenoid.
So now we know the origin of the all heads of the triceps.
Above is lateral head. Above the groove is lateral head.
Above the lateral head, below the medial head. Okay. For the lower end, so we have the medial epicondyle and lateral epicondyle. The medial epicondyle we call the common flexor origin. So all the flexors of the forearm, they come out from here. Here in the forearm, we have around 20 muscles. So the flexors are 8 and the extensors, they are 12, and they are arranged in layers, superficial layer and deep layer. Okay. So most of the flexor group will be coming out from here, medial epicondyle. And most of the extensor group will be coming out from here, lateral epicondyle. Okay. So those are the important muscle attachment. For the articulation, so we mentioned before, along with the glenoid cavity to form the glenohumeral joint or shoulder joint, type of the joint is ball and socket. For the lower end, along with the ulna and the radius, they will be forming the elbow joint. Type of the joint, hinge. For the important parts about the humerus, the first part will be that the humerus will be having 3 sites for common fracture for orthopedics. So there are the supracondylar fracture here, and there is a fracture shaft and fracture surgical neck. And all 3, they are very dangerous. Why? Because here around the surgical neck there will be important blood vessel which will be forming anastomosis around the shoulder joint, which will be the medial and lateral circumflexohumeral branches from the 3rd part of the axillary. They surround the surgical neck of the humerus, along with very important nerve, axillary nerve. So injury here, the surgical neck will damage all those structures. So there will be hemorrhage, and there will be also paralysis of the deltoid muscle, which is supplied by the axillary nerve. Paralysis of deltoid means that the patient cannot raise the arm above 90 degrees. You ask the patient, okay, raise your arm, cannot go more because of the paralysis of the deltoid muscle. For the by the way, this one very common question also, how will you know that there is injury to the axillary nerve? Yeah, you don't ask the patient to raise his arm because he already fractured. Very, very painful. So regimental band here, you just try to prick or touch. Can you feel or not? If it doesn't feel, so there is injury. Fracture shaft. We mentioned that we have here at the back the spiral groove, so injury of the radial nerve. Radial nerve basically will be supplying all the extensors of the arm and the forearm. So to be supplying the triceps and to be supplying also the extensors of the forearm, right? So injury of the radial nerve will lead to paralysis of the extensors, okay? Extensors of the forearm. And then we have the supracondylar fracture. Supracondylar fracture, this one very common, especially in young children. Supracondylar fracture will lead to injury of the median nerve because it will be passing through here directly, and also the brachial artery. Okay, for the injury of the brachial artery, it will be having a very common sign we call Volkmann ischemic contracture. Volkmann ischemic contracture, this one due to ischemia to the tendons of the flexor tendons, or there will be ischemia, so they will get fibrosed, and then they pull the fingers like this. So we call Volkmann ischemic contraction for injury of the brachial artery and also injury of the median nerve. So those are the common site for the fracture. For the important question also, the growing end of the long bone. So each long bone will be having a primary ossification center and nutrient artery. Okay, and this nutrient artery will be going directly to the primary center. So the primary center, this one act as a factory, so it will be producing all the substance need for ossification. Okay, so the growing end for the humerus are going to be the lower end. The lower end. Okay, how can I remember? You always remember that from the knee I flee to the elbow I go. Okay, to the elbow I go, from the knee I flee. This is the direction of the nutrient artery. Okay, to the elbow I go means that the nutrient artery will be going directly here. Okay, so this will be the factory, will be in the lower end. Okay, so sorry, to the elbow I go, from the knee I flee. Okay, so the growing end are going to be the
So it will be going like this.
Yeah.
Right.
Yeah.
This is the approximate fracture.
So the side actually is there's like you have the least muscles there. So there's
there
the
is no
least
muscle.
support.
No muscle.
Okay, and
Beside that, the capsule is lax.
capsule is lax. The capsule is lax and there is no muscle support. All the muscle will be above. Okay, so why the shoulder rarely to dislocate upward? Because all the muscle will be coming out like this, forming a socket. And there is also a secondary socket, which will be the ligament between the coracoid and the acromion, called the coracoacromial ligament. Okay, this ligament will be very thick ligament here, and this one will prevent the head of the humerus from dislocation upward. But it's very easy to dislocate downward, very easy. And also, if you can see, one of the main opposite the knee joint, the hip joint, sorry. So for the hip joint, if you look